Welcome to Flames of Knowledge, a CFSI podcast where we analyze federal policies, spotlight leadership, and tackle issues that matter to the fire and emergency services. Stay informed, stay engaged, and let's get to work. Welcome to Flames of Knowledge, a CFSI podcast.
Hello, and welcome to another installment of our Flames of Knowledge podcast series. Today, we are going to focus on EMS, specifically on a program launched by a fire department to address a mental health crisis, a crisis that we are seeing occurring across our nation. What makes this program unique is the network of partners engaged in addressing this crisis, including the city council and various healthcare providers, and the level of care provided to the patients. CFSI learned about the Joliet Fire Department's Community Mental Health Program when the department applied for the 2025 CFSI Masimo Excellence in Fire Service-Based EMS Award. The selection committee, composed of representatives from CFSI, the International Association of Fire Chiefs, the International Association of Firefighters, the International Fire Service Training Association, the National Fire Protection Association, the National Volunteer Fire Council, and Masimo, were equally impressed with this program, thereby selecting the Joliet Fire Department for the 2025 award, which was presented at the 35th Annual National Fire and Emergency Services Dinner in Washington, D.C. before 1,500 state and national fire service officials. I am honored to have Joliet Fire Chief Jeff Carey participating in our podcast to share information about their mental health program. He is joined by Deputy Chief of Health Services Aaron Kozlowski and the Office of Emergency and Disaster Management Director John Luckancic. I hope you, the listeners, are inspired by what you learn. Perhaps you may decide that your department should explore developing a similar program in your community, in which case you will want to contact Chief Carey to learn more about the details. So, gentlemen, again, thanks for joining us. And again, we were so honored to recognize your fire department for what you're doing. Not only did we do it in Washington, D.C., but we also had an opportunity to do it at a city council meeting in your community. I think it was a month or so ago before the city council members, because as we all know, they had such an active role in launching this program and funding this program. So again, thanks for joining us.
Thank you.
Thanks. Yep. So let's start with some questions then. Let's kind of start at the 30,000 foot level. So what did you discover in your research about how we're falling short in addressing the mental health crisis in this nation?
So I'll start. Jeff Carey, Chief Joliet Fire Department. In 2020, the Joliet Fire Department was starting our community risk reduction programs, and we were doing a community risk assessment. And while we were doing that assessment, we realized our mental health calls were accounting for almost 15% of the responses we responded to. And if you added in substance abuse, it was about 20%. So I know a lot of people are having issues with falls, but for us, that just jumped off the page at us of, this is a big issue and what could we do to address it? So to address it, we started looking at kind of nationally, locally, what other fire departments were doing, what the federal government was doing. We found a lot of interesting stats on mental health, and then we kind of really found that here in Will County, that using the Will County mental health or general health needs assessment, found that access, cost, and transportation were the three biggest barriers to people receiving mental health care in Will County. In Illinois, there's about a 350 to 1 provider ratio. In Will County, it's 600 to 1. So we had a really big issue with getting people to definitive care, which resulted in us seeing repeat callers for mental health over and over and over because it was taking them so long to get to that definitive care aspect. So they would call us constantly as their crisis care, go to the hospital, it would take 4 to 6 weeks for a general appointment. Well, they couldn't wait that long, so they just called the ambulance over and over and over again. So that's kind of where we found our biggest problems.
So another issue that we found during all of this. This is John Luckancic, emergency management. One of the other issues we found was that our fire department and most fire departments in our area don't address traumatic stress related issues at all. Many times we show up to these horrible events for people, and we don't have any initial crisis care. And we don't usually have access to definitive care after that these folks could use. So that was another thing we saw as an issue outside of the definitive care was just the volume of traumatic stress that happens in our community, that needed to be addressed as well.
And one other thing that was actually really shocking as we sort of went down the journey was the numbers that the chief just talked about, that in the teens for mental health calls was exactly the same here as it was. We were training one of the communities, one of the small communities of Will County, and the volume was quite a bit less than ours. Their numbers are exactly the same as ours, exactly the same as Chicago's. So it's not like a big city problem or a mid-city problem or a small city problem. The numbers are almost exactly the same for EMS transports and responses for mental health, which is sort of shocking.
So, what do you think is the biggest impediment for people suffering from mental illnesses to seek the treatment? Just the availability of treatment, or is there a fear associated with contacting the care facilities? From your perspective, what do you think that impediment might be?
I think the biggest thing was those barriers we discussed. The length of time to treatment was a big issue here. When it was taken, if someone was in crisis and it's taken them 4 to 6 weeks to get an initial appointment, that they never resolved that crisis, which resulted in us over and over. And then the cost, the people in Illinois on Medicaid were having a really difficult time. Private providers won't accept Medicaid. So it was only left with the health departments who were overloaded with Medicaid patients. So they really struggled. And then the uninsured really couldn't access it at all.
And another impediment was, I just think, even lack of education. Like, some people don't even know where to go or how to start the process. They just no idea. If you don't know anyone that's ever had mental health services. So it was a lack of education on how you go about getting the services you need.
And we all know too that stigma plays a big role in this. So whether it's self-stigma or perceived stigma or actual stigma that's coming from the population, and that was part of the education too of trying to get past that stigma to make people confident that they could seek treatment and wouldn't be stigmatized. So all of those things combined were really important in the program starting.
So, a large percentage, and I don't have statistics, but a large percentage, as we now know, people dealing with mental illness is the homeless population, people living in shelters. How did you go about alerting them? How did you go about educating them about this program that we're about to discuss?
So when we started our community risk reduction program, we met with 93 different organizations here in the city of Joliet. 2 of them were our homeless shelters here to discuss those issues. And what we did with the homeless population here was at our 2 main shelters in town, we set up a room in that shelter where they could go, they could schedule their appointment. The directors of the shelters kept on task to make sure they went to that appointment. They set up a private room just like this with a camera and computer screen where they could do telehealth sessions through our program to get the mental health care they needed.
And it's important to note, like Chief Carey says, that telehealth is a big part of this because part of that stigma is I don't want to have to go to a doctor's office or be seen at a mental health facility. So now people could get on their digital devices, their phones, their computers, and actually seek treatment from qualified clinicians in a telehealth environment, and making that more widely available, especially to the homeless population, was kind of a game changer with all of this.
That's good. Okay, so let's talk about your mental health program. What were the main goals when you established this program?
So originally it was we sought out a lot of our repeat callers, and why were they calling over and over and over? We had and when we looked at 3 individuals who were our worst, those 3 individuals were calling well over 300 times a year. One individual called 250 times a year. One was calling over 100 times a year. And so with those individuals, kind of really got into find out why were they calling. And then this program is expanded besides just mental health care. We found out a lot of the causes were the root cause basic needs that they weren't having. So we've developed programs off this program to address the basic needs of the community, and bringing that all together with mental health, getting their basic needs, all these things taken care of at the same time, has resulted in those 3 individuals, the 18 months following that, the one individual had only called one time, one called zero, and the other one called twice, and he was just calling to say hi because we hadn't seen him in so long. So it really diving in, getting their mental health taken care of, getting those basic needs they need taken care of, resulted in those people never using us at all anymore. And then one of our busier ambulances, Ambulance 6, we had talked to them about a year into the program, asked how it was going because they see a lot of these calls. And they said that they had went out, there was 10 people that used to call them, seemed like daily, at least every 3 days. So they hadn't seen them in months. So they went to the houses to check on them to see how they were doing. And they said, we don't need you anymore. Because when they were calling that every three days, it was because the hospital gave them 3 days worth of meds. And then it would take 3 to 6 months to see a psychiatrist, sorry. And so they were going to call the ambulance every 3 days as part of their plan. Well, once we intervened, got them to the care they actually needed, they didn't need to call us anymore. And now if something did happen, they don't need to call us. They can go right back to their therapist. As once they're in the program, they can schedule an appointment on their own at any time they need it. And so instead of calling 911, now they just go right to their therapist. So it reduced those people, those repeat callers over and over. And then after the first year, we did see a slight reduction in the amount of calls. And suicide wasn't initially a driver. It was more for the volume of calls, what we were looking at. But when we worked with our schools, who we'll talk about in a little bit, they were tremendous at getting this out to the kids. We had a big teenage suicide problem here. And after the first 2 years of the program, we dropped our suicides by 52%, and we didn't have any teenage suicides in 2 years. After the year before we started the program, from where we're sitting here today, we had 12 high school age suicides within a 15-mile radius of where we're sitting. So that wasn't really what we were going for originally, kind of got into that, but that partnership with the schools and getting that to that teen population, that easy, quick access to care is what really kind of helped drive those numbers.
And one of the goals was kind of like we're almost doing America burning over again, right, from the early 70s, was to try and sort of put ourselves out of business. And I just looked at the stats real quick here. When we started back in 2019, we've dropped our mental health calls about 1% of our, each year it ticks down a couple tenths of a percent. So compared to 2025 projected, compared to 2024, we're going to drop about 100 mental health calls just responding on the ambulances. So that was the other kind of, like you talk about big broad goals, was to reduce the number of times that the ambulances and the engines had to respond to mental health calls by getting the people in our community the definitive services they needed.
So let's talk specifically about the partnerships involved and the various roles that these partners play in this program. So if you want to take it from there.
Yeah, so kind of how it started, John Luckancic, he had been wanting to do more mental health within the fire department for years. So in 2019, he started a peer support program in the fire department that kind of launched us down into this mental health road. And it's been really successful, kind of got guys more aware of their own mental health and all that. And and then in 2020, we were really looking to how to get it to the community. COVID kind of put it on pause for a little while. We really didn't get back to it till 21. And we were working on all these things, how do we solve all these problems? And our biggest issue we couldn't find a solution for was the definitive care aspect, because everybody was full. We didn't have anywhere for them to go. And it was just by chance, the city manager at the time was talking to a company called ThriveWorks, who they wanted to come here to be part of the city's employee program, just to offer for city employees. And they were offering, you could see somebody within 24 to 48 hours, and it was fully covered by the insurance, which was great for city employees. But we're like, how do we get this to the community? They're the ones who are really struggling. How can we get this kind of service to the community? So we worked with ThriveWorks for 6 months probably. They had to kind of redo their program model, and how could we get this out to the community? And then we had to make it cost-free. So if by making it cost-free, we take whatever insurance they have first, and then we pay the balance. If they don't have any insurance, we pay for the whole thing. So then we had to go to the city council and tell them, we got this idea, this program to help the mental health in our community. They estimated that it would cost $400,000 a year. In our community is 150,000 people. So $400,000 a year for 150,000 people. The cost savings to the community is tremendous. We estimated, the untreated mental health in the Joliet community at about $135 million a year. So the $400,000 a year, even though it sounds like a big number, the cost of not treating it is even larger. So they were on board with it. Then when ThriveWorks came on board, that we had our provider. And then also the biggest partners for us were probably the schools. We didn't probably realize how good they are at getting information out to the community. They took the program on and really did a great job with it. They put it on the kids' homework page. It's all over the schools. So the kids can access it. If they're at home, they have a problem, there's a QR code on the bottom of that screen. They can click and get access to it. We did have a little resistance at first with the counselors at the school because they thought we were going to put them out of business, and we were telling them, no, we still need you. They're there to handle that daily crisis the kids are going through, but they're not their definitive care provider. And once they realized it, the counselors got on board and loved it because now they didn't have to take all that responsibility. They hear their data issue, and then they have somewhere now they can pass them off to know that they're getting that definitive care. So we had a ton of partners with the Will County Health Department. We use their IRIS system. It's very good at scheduling and getting people in and out. It's a quick, easy way for us to register people. We can do it from the field now on an iPad. The crew's on a call. They can put in 8 questions. They'll get a call back from ThriveWorks within 8 hours that schedule an appointment. There's a lot of times that they can have an appointment the same day, but it's usually by provider or patient choice. Sometimes they're not ready to go that day. So I think they average now about getting in about 6 to 7 days with our, not that they're not available within 24 hours. It's usually the patient's not available within 24 hours. So the townships have been great. We've got all kinds of different small players when we get into our community care program. We have about 30 other partners, but those were the main partners, getting the city council on board, having that ThriveWorks for our mental health provider, and then our schools were tremendous.
One of the other partners that I don't think
the main player early on,
was Silver Cross Hospital. We didn't have a facility through which to have these appointments, and Silver Cross Hospital actually donated a space to us right in the geographic center of Joliet for people who wanted to do in-person therapy sessions. So they were a big part early on in the process as well.
So what was the city council's initial reaction when you proposed this idea for the program?
Yeah, when we first thought about it, we thought we would have a difficult time. So we initially were going out to community philanthropists and trying to raise money for the program through donations. And when we got to the state's attorney, because he gets drug seizure money and all that, we thought it'd be great to feed this program. He said, well, what is the city council going to put up? And we weren't sure. So some of the people we were asking to donate money thought, well, they were willing to do it, but they wanted to see what was the city's buy-in with it. So we took it to the city council. It was unanimous pass. Everyone was for it. Everyone wanted to give it a shot. And now they talk about it all the time because every one of them has constituents in their districts that use the program that call them with these tremendous results. So it's kind of steamrolled into now. That's something that it's not a council meeting I probably go to where one of them don't come over and talk about somebody in their district that's using the program and seeing the benefits of it.
And interestingly, some of the council people we thought were gonna have the hardest time with were like there was really not a whole lot of convincing. The chief, we kind of met with all of them and sort of talked them all through the program so they would understand where this money was going to go. And some of the ones we thought would be really hard sells were just right on it. They had some good hard questions, but it wasn't that they were opposed to it. They just really wanted to know when they were questioned, what are we doing all this? What are we giving all this money for? They just wanted to be able to speak intelligently about why we're doing this. So it was sort of surprising in some ways too.
And I think that's what he hit what was important. We brought them all in individually beforehand to explain the program, what we were doing before it went in front of the council.
That's a smart move. So mental health, as we all know, it's like it's like a cancer. Sometimes it's curable, sometimes it's not. Sometimes it might take 2, 3, 4 years, before there's any type of progress being made. For the beneficiaries of this program, can they keep going back, to these services, and will payment be made, through the city council and others, or is there out-of-pocket expenses for these people who do require that long-term level of care?
Yeah, within the first 2 years, the costs were not that drastic, so we were fine. People could go as often as they wanted, as many times they wanted. In this past year, in 24, it grew so much where we were going to start running out of money, so we limited it then to 26 sessions a year. And talking with drivers, counselors, talking with our social worker, it was like if somebody needs sometimes more than once a week, that they might need inpatient care or something more than what we're providing through here. So that seemed to work, and people are happy with it. But we also, with that, they can request more sessions. So the therapists are seeing through ThriveWorks, and our social worker will discuss if somebody needs more. And if it's somebody who's having those long-term effects that where they really need it, we do allow them to have more. But what we were finding originally was since it was free, some people were using it just to, as a talk session where they don't need to be there every week for that. But the ones who do need it, we don't want to keep that from. So all it is now is a process where they call us, they tell us why these people, whoever they're seeing, need more appointments, and then we approve it. But in the past year, we've acquired a lot of alternative funding now. So now we have a lot of money now to fund it through other sources that we didn't have before. So now it's easier to allow those extra sessions.
And we also they're offered 26 sessions for the year, which is every other week. And the average number of appointments that people have is like 12.3. So like usually it's like it sort of ebbs and flows, right? You have something bad happen and you need more, and then you'll sort of graduate off, and you might not need to talk to a therapist for 18 months. And then, but it's simple enough. Once you're in, they can contact ThriveWorks again and talk to their counselor to get the services they need. So the 26 is quite a bit more than the average appointment number of appointments that a person would actually or typically uses.
So I'm sure a number of your patients, they're homeless, or they just don't have the ability to schedule appointments or seek out the treatment. I mean, you mentioned social workers. Who's kind of like coordinating things for the beneficiaries of this program? And I'm speaking more specifically about, say, the homeless and the downtrodden.
Yeah, so here we have a fire department social worker. That kind of came by chance too. It was early in our community risk reduction program. We were working with the Will Grundy Medical Clinic, and they had an intern they needed somewhere to put, which they're located right behind our station here. So they're like, we can still oversee them. We just couldn't have her in the office. Could she come here and work with us? And once we found out the tremendous amount of work that a social worker could do within the fire department, we ended up getting our own full-time one, which has been, we could probably use 4 of them. But she does a lot of that initial intake, works with all the shelters, works with all our other community partners to make sure that they get connected in there. And then that community care program that came off the mental health program, we now have a community paramedicine program where we have 2 community paramedics. They go out on the street, deal with that. They'll visit homeless encampments. They bring them stuff, they offer them, here's the services, because we try to get them off of the streets. Some of them don't want it, some of them aren't ready for it. If they are, we can usually get them into the shelter to try to work them through there to get them into permanent housing. But the ones that don't, the community paramedics said they will make regular visits to these sites to make sure that they have these services they want. And if they do, even if they're not in the shelter, even if they're in an encampment, they can still go to the shelter to get their mental health services. We also were setting up with the library. A lot of them go to the library in the day. So they can also access this through the library. We have it at our Spanish Center in town where they can access it there. So we have different places in the community where they can go in to access it. But our community paramedics also go out, besides doing the home visits for the regular community paramedicine program, they also go out and visit people on the streets to make sure that we're meeting those needs. And the goal is to get them off the streets and into permanent housing.
So your personnel, your firefighting personnel, what about the training for the personnel? Have you changed the training? Have you increased the level of training to address a specific problem with mental health in your community?
So one of the things that we realized is we're mostly made up of licensed paramedics who receive a certain amount of training during their preparation to get licensed. But we realized they get a good background, but they don't get specific instruction on how to deal with mental health issues in the field, how to deal with crises in the field. So what we did is we put together a program that we call Crisis First Aid for Paramedics. It's a program that we developed here on our own because we found that nationwide and in the curriculums that mental health care was kind of lacking. So what we did is we took a lot of different programs, studied them, found the parts that were useful to paramedics in the field, and we created a program that usually would run about 8 to 16 hours, and we whittled it down to about an hour for our paramedics with a practical portion so they could learn the 7 steps of crisis intervention. A lot of people think you have to be a clinician or you have to be a professional to do crisis intervention, and you don't. Civilians get trained in crisis intervention every day in this country, and you don't have to be a social worker or a psychologist to do it. And we found out that with the background that paramedics already had in their education, a lot of the preparatory work they didn't need. They didn't need to learn what depression was or what eating disorders were, or any of those different issues. What they needed to learn was how to say things, what to say, and when to say them to get the responses and the direction that they needed. So crisis first aid has been taught to about 600 paramedics in Northern Illinois so far. Other departments have asked us to teach the program. But all Joliet firefighters are trained in crisis first aid for paramedics, which allows them to begin that continuum of care at the person's bedside and get them to where they need to go.
And John, when he says we, it was he developed the program. He's throwing the we around, and he asked the chief to sit through one of the classes, and chief made it about an hour. And if you know firemen, that's about all you get. You get about an hour, and that's the end of being able to pay attention. So we customize it down to the attention span of like me as well, like everybody, like, right. So, and then the practicals is like where you saw the light go on with our medics, where they said, oh, because they really did most of the stuff. They can build rapport. Paramedics do it really very good all the time, every day. So that wasn't one they had to hit on. There's just a couple of the things in the 7 steps. And once they got that, it was lights on. And Chief got an email last week from a guy who there was full arrest. His wife ended up dying. But his email was, I don't know what your medics did. They just made me feel better. And if you ask the medics, they probably don't know what they did either. But just by being there and with these quick communication skills, they were able to make this person feel better in a 15-minute span.
So Chief Kozlowski brings up a great point that this program isn't just for mental health sufferers. We go to traumatic stress calls for service every single day, and our crisis first aid and our mental health program can be used for those people who experience the traumatic stress. Like Chief Koz said, the family member who had the full arrest and had the family member die, well, that person didn't call for a mental health problem. They called for a patient not breathing, but they were undergoing traumatic stress at the time, and we can use this program to help them at the time of the stress.
And Chief Carey didn't talk about this, but a lot of the continuum of that. So our guys see this person at the scene, and in 48 to 72 hours, initially the community risk reduction division would call them back, but now the social worker, the community paramedic does. And when they call back, most of the time to offer more services, most of the time do people say, no, I don't need it. But it's really the thing that I needed was to know that somebody out there cares. And you guys and they said, just call us back if you need help. But most of the time, it's just the follow-up is the key to all of this, or a huge part of all of this is for the person to know that there's somebody there. And if they need services, you call the fire, like everything else, I guess. If you don't know what to do, call the fire department and we'll figure something out for you. But specifically with that, it's the callback really changes these people's perception of what's happening.
I would like to add that we put together a template here that any department can do this. You only need a few things. You only need a few things to make it work. Number one, you need a fire department because as Chief Carey always says, fire departments are the most trusted brand in America. People trust their fire departments. So you need a fire department to start this process. A lot of people don't necessarily want the police to do this or want private entities to do this. They want the fire department to do it. The next thing you need is a community partner in healthcare, like we had Silver Cross Hospital. And the last thing you need is a public-private partnership between the fire department and a mental health provider that can get people in fast. So we designed this program so that it's copyable anywhere in the country. And Chief Carey, send your emails to Chief Carey, millions of them. He'll tell you how to do it. But it was a step-by-step process that we identified, a 4-step process that if you do the steps, you can do this on your own fire department and make it work in your community.
Well, John, I think you mentioned 3 contributing factors, but I think you forgot the 4th. And it's called city council.
Oh, well, sure. Absolutely. Well, the thing is we were on our way to getting private funds for this. So I bet we could have funded it anyway. We just had the city council was just all on board. So Chief Carey's got a way about him where he can convince anybody to do anything. So we probably would have got it funded somehow. But you're right. The city council was a godsend to make this whole thing come full circle and to get actually put into practice. So you're right.
And we didn't mention it before, but it's super important. It's one thing to give mental health lip service, but the chief was at every single, he missed 2. We had 35 trainings, right? And he was at all but 2 of those. And he sat there in a month, he went to probably 80 hours of training because it was super important that the line saw that the leader of their department said, this is important and we're doing this. So for the chiefs out there, because Chief Carey's talked about this at some of the CRR conferences and stuff, and how do you do CRR in your department? Well, the chief has to be visibly bought into the whole thing. And he's done that. I don't know how he does what he does, but he's done that extraordinarily here.
I think just one thing to tie into theirs was you could do this program without any funding. I mean, it wouldn't probably work as well, but the Christ First Aid that John does, we get so many calls from that follow-up of just the way we went through the crisis steps on the scene. And like you said, it's not for the mental health calls. It's for all these traumatic stress calls. Somebody witnessed a bad car accident, a shooting, a family member die. Now we have that battalion chief responds to those calls. He pulls that family or bystanders aside, assigns someone to go through that crisis intervention with them. And sometimes that's all we need. But when we call them back and follow up, that's where they get it too, and like Chief Koz said earlier, that it's just knowing that somebody cared and somebody was there for them. And sometimes that's all then they need. And they know they can call us back if they need us. So even if you didn't have the funding to get the definitive care part, you could use your local providers. You might still have that delay, but you could still do the majority of this program with no funding at all. It's just getting the firefighters and paramedics trained in Christ First Aid. And it's not that difficult. We found out it's just a little bit of different stuff they do in their assessment. And the next thing you know, they do it in their everyday assessment on everybody. And we get calls weekly from people that it's affected without the definitive care side.
I assume you've heard from other departments who are interested in learning more about your program?
Yeah, we in the beginning, we actually had people reach out from Maryland all the way to Colorado, and we're right here in Illinois in the Midwest. So it kind of started out pretty broad. We've even had Green Bay, Wisconsin. We're all Bears fans down here, and even though it's Green Bay, but when it comes to this, fire departments and that are great. Even though that was Green Bay Police Department, and I don't know, some of them, with Rockford, it's another bigger city in Illinois. We did the training with them, then they took it back to the department. We don't know what they did with it. They probably tailored it just like us. You tailor it to what works for your community. Rockford already has a really robust community paramedic program. It probably got tailored into their program. So it doesn't have to look exactly like ours. It's what we've done too. We've taken everybody else's information and great ideas, molded it into what works for our community. But those are some of the far ones, but pretty much everyone around us is doing it because they seen the impact that we had. So almost every in Illinois, besides counties, each county then is divided up into townships. And I think there's 22 townships in Will County, and we've got most of those townships on board. And what the townships are, they're another funding source that they provide services. So they become a great funding source for these other fire departments around us to set up funds and that. So pretty much everybody that touches the city of Joliet, and the city of Joliet's 65 square miles. So we have a lot of communities that touch us. Everybody around us is doing it. We've got other departments still interested. We were waiting. We received some state funding. So this thing's going to go countywide now. So everybody in Will County, which is a little over 700,000 people, are going to be able to access this program.
Yeah, you mentioned state, and I know you've heard from state leaders as well as federal officials who are interested in learning more about your program. You want to talk a little bit about that?
We have, when we first came up, same thing with this idea, we approached our city council. We also approached all our local state reps and senators, and they weren't against the program, but I think they didn't really understand it. The federal government had just put out a bunch of different programs, and they thought that was going to kind of solve the problem. And we were telling them what the gaps in those programs were, and that our program was meant to kind of fill those gaps. And, but nobody wants to spend money on something that's just an idea. So after we had a year in and these results started coming in, then that's when they started wanting to get more behind it with funding to provide. So our local legislators were on board pretty early with trying to get us money through the state rep Natalie Manley. She secured last year's fiscal year budget for the state, $1.9 million for the program to go to the county. The way it was set up, it didn't allow us to get it to the whole county just because of the way the funding was set up, but they re-upped it for this fiscal year. So we're hoping here in the next month or so to be able to get that out now to the rest of the county who's not doing it. But out of the 700,000 people in Will County, about half of them are already covered because the fire departments around us are already doing it. So we're just missing mostly our southern half, which is more rural. The northern half of Will County is more municipal, more suburb of Chicago. As you get south of us, it gets more rural. So we want to get to them, but they were real great. And then after we were out at your guys' CFSI program in DC, we met with Senator Durbin, Senator Duckworth, and Representative Underwood. I was about to say the wrong name. And Senator Durbin has put an appropriations bill in for us for funding also to expand this program. So they wanted to originally do like a 3-year pilot here and then expand it to the whole state. But through your guys' conference in Washington, being able to get to those federal leaders, now it's gained more traction of looking like sooner than later, we can have this through the whole state of Illinois.
Sounds good. We're kind of nearing the end of our podcast here. And so before we kind of finish things off, is there anything else you'd like to add?
I think for fire departments out there is, before we started this kind of community risk reduction, mental health stuff of the fire department, we were having a rough time here in Joliet of the council not knowing why they needed the fire department. Because we used to have a lot of fires. The fires were down. They would say it all the time. You guys don't go as many fires anymore. Why do we need all these firefighters? This is what changed their mind. This is what changed their. We've increased our staffing so much because of these programs. We showed them what else the fire department is capable of doing. We changed the kind of image of us that was going on with the city here. It's no longer, the patch actually it's great for us with being the trusted brand, but it was hurting us because all they seen us was as a fire department. These type of programs got us into the community. got the community support behind us, got the council support behind us. And it's been a life changer for this fire department to move forward. And now we're going into more and more different programs. Just, changing with the times and expanding like the fire department's already done. You get out of your comfort zone and go into really what is the risk to the community. Here it's no longer fire. There's these all the other risks. So as we change with that, that's what got us back in the council favor and has allowed us to do all these things by just getting out in that community and addressing the next big risk in your community.
Chief, that is a great message to end this podcast on. I thank the three of you for participating, and I thank the listeners for participating as well. I know Chief Carey is always willing to answer questions from his colleagues across the country about the department's program, and so don't hesitate to contact him. As I mentioned earlier, CFSI and Masimo acknowledge the Joliet Fire Department with the Excellence in Fire Service-Based EMS Award. The award recognizes fire departments for innovations in the delivery of emergency medical services. Please consider applying for this award if your department has launched an innovative program in EMS. This program offers us a great way to share with other fire departments the many innovations in emergency medical services taking place across our nation. You can learn more about this award on our website at www.cfsi.org. Thanks and stay safe.